1 in 3 Americans face barriers to accessing specialty care. 1/5 of Americans live in rural health areas, while only 1 in 10 physicians practice there, leaving 2 or 3 Americans without any access to specialty care that they really need when they need it. How are modern health systems overcoming this barrier? You're listening to the Innovaccer Healthcare Podcast, where we speak to the real healthcare changemakers and understand how they're tackling the challenges of delivering healthcare in an ever-changing ecosystem. I'm your host, Dr. David Nace, Chief Medical Officer at Innovaccer. Today, I'm joined by Dr. Edmund Pribitkin, Executive Vice President, Chief Physician Executive at Jefferson Health. With over 30 years of academic leadership and 10 years of executive C-suite experience under his belt, Dr. Pribitkin oversees over $1.6 billion in net patient service revenue for physician care services at Jefferson Health. Hello, Edmund. Tell us a little bit about yourself.
Hello, David. Thank you so much. By training, I'm an otolaryngologist, facial plastic surgeon. In that training, a lot of what we do is really work with some of the key areas that determine an individual's ability to communicate with the world and to some degree, their sense of self. Very fortunate to have had a long clinical career. One of the things we do at Jefferson is that our executive leadership in the medical group continues to practice and continues to engage with patients. So I continue to operate every other week and see patients in the office every other week. It's an important way to make those connections that are so critical to actually understanding the challenges that our patients and their families and communities face. I've been at Jefferson for 34 wonderful years. I have seen us grow from a small academic center, hospital, to a far-flung network across all of eastern Pennsylvania into New Jersey, and have now over 30 hospitals with 2 rehabilitation centers, literally 100 of the different ambulatory sites. And that has brought its own challenges, but it's also brought a tremendous number of opportunities to scale and to provide care to far-flung rural communities deep in the Poconos and other areas, to also look at areas that have been under-resourced with healthcare opportunities in the inner city and in areas that, quite frankly, are economically depressed. All of that is part of the mission of trying to improve access for our community. The truth is that is what is distinguishing Jefferson. We are committed to access for our community. It's one of the areas that our CEO, Joe Cashone, and our head of the health system, Dr. Bali Yahia, have really stressed in terms of our commitment to different parts of the community and to each individual patient and family member. So what you're talking about today is really part of our DNA, part of our mission for the organization, so to speak.
Wow, that's an impressive growth trajectory, and it's a broad responsibility. And I love the mission for sure. When you think about the state of specialty care today, how would you describe it, particularly the tension between patient needs and delivering the care when they need it in the way they need it?
You know, I think you've really hit on one of the real challenges for our healthcare system in general. We don't have enough clinicians. We don't have enough doctors, enough advanced practice providers, enough of the ancillary staff, such as community health workers and others, that can really deliver the care that's demanded by the public. Even in those areas where, in a sense, we're oversupplied, like, right in the academic center, even then it's very difficult for people to access the care that they need when they need it. And so what we've looked at Jefferson is we've said, what are those critical areas where, in my view, there's the most anxiety about healthcare. Where can we relieve that anxiety by providing the care that is needed? I'll give you an example. What is more challenging than having a cancer diagnosis or
Mm.
having a family member have a cancer diagnosis? I've had that occur in my family, and I have the advantage of picking up the phone and calling the head of the cancer center and saying, in my case, my daughter having a
Mm.
leukemia, and I can immediately get access to the experts who can then take care of my daughter or family member. But that doesn't happen for everybody. So, how do we do that for everybody that suddenly gets a cancer diagnosis? How do we put them into the system so they don't have to struggle with getting the answers that they need? And so, at Jefferson, in reliving some of the workflow that's needed to get that done, what we realized was we just don't have enough cancer doctors. We don't have enough cancer specialists to get this done in the time that's required. If you call up and say, I have a diagnosis of cancer, I need to see someone, you get a response in most systems, well, we can get you in about 3-4 weeks, you
Mm.
know. And if you particularly have a challenging cancer diagnosis, maybe they'll get you in 2 weeks.
Mm.
So we said, this is unacceptable. We can't have this anymore. So we came up with a same day, next day cancer appointments. So we now have nurse practitioners that work from early in the morning to late at night so that they are really available for anybody that wants to call with a cancer diagnosis to get put into the system. Why does that work in cancer? It works in cancer because, believe it or not, treatment protocols in cancer are really well spelled out by the NCI, the National Cancer Institute, and others. So a nurse practitioner can take a call like that, talk to the patient, access their records, and within 45 minutes to an hour, have a treatment plan for that individual where they can be reassured that their care is going to be delivered. Now, there still has to be refinements and you have to get to know the doctors taking care of you and everything else, but you're in the system. You can sleep a little better that night because you know that there's someone that is going to be looking after you and coordinating your care. It was a system that we put into place where we basically needed to hire up a large number of nurse practitioners, honestly, to do this work. But it's a system that is really proven very effective in terms of relieving some of that anxiety and providing that care. And it doesn't matter where you are. Same day, next day system is a pure virtual system. So you could be in the Poconos, like we mentioned earlier. You can be in the inner city. If you have access to a device that can allow you to have a visit virtually with the clinician, then we can make it happen. That's been incredibly empowering to relieving that particular aspect of the care. Want to hear one of the big surprises that we found out?
Sure.
A lot of cancer diagnoses are made in the emergency room.
Mm. Mm.
We did not expect that. We actually expected people to be calling because their primary care doctor said they had a lump in the breast or they have a PSA, a prostate specific
Sure.
antigen that is elevated. But actually, about a third of our referrals are coming directly from the emergency room. Literally, someone's getting a cancer diagnosis in the emergency room. They're not sick enough to be admitted into the hospital to be cared for there. So the ER docs are basically having them access the same day, next day system, and they're boom in the system getting cared for their cancer instead of getting a slip in the emergency room to have a phone call sometime to get an appointment for their cancer diagnosis. So,
Mm.
truly gratifying to see that happen. You go from going into the emergency room, finding out a horrible potential diagnosis, to at least getting put into a system where you're going to be cared for. So one of the real surprises of the system, and we're branching that out now. We're doing same day, next day in cardiology, because that's another one that seems to be coming up, whether it's from the primary care doctor or the ER, that is a frequent, not ill enough to be admitted,
Mm.
ill enough to need care and very anxious about the care. So just some of the lessons learned.
That's an awesome story. And I, too, like you, often call the administrator on call when I want to get that appointment compressed. And not everybody, 98% of people don't have this kind of mechanism. So this is a great story. Let's talk about other drivers to barriers to access. So costs, right? So we know that we're seeing higher out-of-patient costs for patients, out-of-pocket costs for patients. That many specialists, for a variety of reasons, are excluding uninsured patients or have difficulty taking a significant number of Medicaid patients, particularly with changes going on in the Hill. How much does affordability play a role in barriers to access to specialty care?
Well, we know this statistically, that it plays a huge role, that in point of fact, for many patients, sadly, it's the choice between feeding their children, buying new shoes, buying new clothes, or taking their children to the doctor's appointment to get an antibiotic for an ear infection or whatever. That's something that shouldn't occur in the United States, honestly. Shouldn't occur anywhere, but we need to do a lot better in that regard. I will say that at Jefferson, all of our employed physicians take Medicaid. They all take Medicare. They all are part of that program. That part of the challenge is that because the Medicaid rolls have been reduced, there aren't that many people that qualify for Medicaid anymore. And that's the safety net that doesn't exist right now in Pennsylvania and in New Jersey. It's all these individuals that are going without insurance, that don't qualify for Medicaid. We'll take care of them. We'll try to put them into programs where they can get a Medicaid benefit, or for children, a CHIP benefit in Pennsylvania. It's so critically important that we're able to provide that care. We don't force a patient to take our particular health plan, Jefferson Health plan, but if they have no health plan and they're coming to see us, we have a Jefferson Health plan that takes care of over 300,000 Medicaid and Medicare Advantage patients. So we do have opportunities for those individuals to access the care system. Part of it is education. We need to do better with our community health workers. We need them to get out there and tell them, folks, that yes, we need to make it possible for you to get health care. We need to make it possible for you to afford the health care that you get. It's the copays even keep people that are working, from getting the care that they need. We have over 60,000 employees, and they and their families need health care. And sometimes they actually, despite the excellent plans that we offer for benefits, they forego getting the health care because they don't afford the copay or they can't afford the time off of work. So part of our benefits plan restructuring is to make sure that they are able to get in to see the doctors. We have a system in place where if an employee calls our 1-800 number at Jeff Connect, they will be speaking to someone who will advise them, hey, we can get you an appointment to see someone for this particular problem, or you need to see our urgent care doctor, or you need to see our emergency doctor. So if they make that phone call first, then if they do end up getting advised to go to the urgent care or get advised to go to the emergency room, we waive their copay. And if they admitted, then we waive their admission, copay. Why do we do that? Because we would like to deliver care at the right moment, and we would prefer that people don't just use the emergency care, as a substitute for a primary care doctor or an urgent care visit. And so you said the right care at the right time. Part of that is education, part of that is facilitating people wanting to do that rather than using the emergency room as their primary care doctor. And if you look across our benefit structure and you see where the costs are, when you have individuals that don't have a primary care physician, the costs are actually considerably greater for them in the long run because they don't see the doctor, they don't necessarily access the system except in emergencies. And so it becomes a little bit challenging for them. If we can make that easier, get rid of that friction, get them to the right place at the right time, then we not only benefit them in terms of their care, but we benefit the system and ourselves, honestly, in terms of the cost. So it would be great to have similar type of systems in place for individuals that aren't employees, et cetera. And we do have some of that for folks that are part of our insurance plan. But these are the things that systems as a whole and across the country need to start working on if we're going to guarantee the access that's necessary to the specialists and others.
That makes sense. And I hear the compassion in the system of trying to alleviate the kind of barriers around timing and costs for patients. So that's wonderful. And as you can see, I just lost my lighting, so I'm going to try to read that.
It's like someone turned on a UV bulb.
That's right. That's right.
Blacklight type of exposure.
That's right. I think I'll be able to get this back on in a second. But we did talk about in the beginning the geographic issues, rural health and difficulty, and you touched on virtual visits. So that's a great solution there. But I have another question. What about the administrative barriers? We know we have this discussion around prior authorization, referral networks, where you have to get referred to a specific network, administrative paperwork, et cetera. And maybe you could speak a little bit about those barriers as well as I get my light on.
Even when you're in with a specialist and the specialist orders certain tests, it's sometimes very, very difficult to get those tests authorized so that they can occur. It doesn't matter if you have an opening for someone to get an MRI scan or any other test. If you actually can't get an authorization for them to come in, that's a huge challenge. I will say that in some of our partnerships with insurance carriers, we now have pre-authorizations that are waived for many diagnoses. We have pre-authorizations that are also waived for physicians that have a history of making appropriate referrals for tests. The part of this problem is of our own making because we practice in an area of the country where litigation is such an important component of the environment. We do have a lot of physicians and clinicians that practice defensively. They order perhaps more tests than are necessary. For example, if you come into the emergency room and you have perhaps a question of a back injury, people will get an MRI scan of the entire spine. That's 2 hours and a lot of cost. If the pain is really just in a given area and you just get an MRI scan, so to speak, of the lumbar spine, that's 45 minutes, a lot less expensive. But people worry that they're missing something somewhere else. And we've, unfortunately, because of the availability of a lot of tests. It's easy to write. It's better to be complete. Um, it's true that sometimes we miss things because we don't do everything for everybody, but we have to be judicious in the resources that we expend. If you have everybody that comes into the emergency room with even any hint of back pain getting an entire MRI of the entire spine, soon the insurance carrier sees that and they're like, well, we need pre-authorization before you get that kind of a study. And that delays care. Not necessarily in the emergency room, but across the spectrum. And so, part of this is the complex interplay between litigation, costs, completeness, the desire to do everything possible, the patient's desire to get everything done that is technically possible, and the cost, And so that's how pre-authorizations started to arise, and you know, it's just gotten worse over time as the technology has become more and more available. So I, I put I don't put the blame on the insurance company. I think that there's plenty of blame, so to speak, to go around. We need to be able to better police the resources ourselves as physicians and patients, and we need to be able to better understand where the pre-authorizations are really to be enabled to be quick, easy, and where they need more thoughtful review. Um, the, there, we're we're struggling, though, to your point, David, because it is one of those areas that absolutely delays care and then, you know, potentially limits the accessibility for many individuals. So pre-auths are tough, but I would say that the solution, because it arose organically in a sense, needs to be solved with collaboration across different parts of the healthcare ecosystem. And that's what we're trying to do too.
Collaboration sounds key, and I like that. But it also raises up another potential barrier, which is many people older people, particularly with complex, multiple medical diagnoses, see multiple specialists and often multiple systems of care. What barrier do you see that in terms of the fragmentation? What kinds of things can be done to help better coordination and uh, collaborative management?
Well, I think I know I'm on Innovaccer's podcast, but I will say that one of the things that Innovaccer has been quite good at is to bring together these disparate areas in caring for someone, to sort of link together these different components. We do that in other areas. Care Everywhere is available through Epic, so that I can see notes that are generated at the University of Pennsylvania, even though I'm at Thomas Jefferson University. There are other systems to do that. Innovaccer helps to bring people together across numerous systems, and Innovaccer is also particularly adept at bringing in private practices that aren't on specific systems that interlink. But it is an ongoing problem. The coordination of care is increasingly challenging. What's the solution to that? I think to some degree, it's patients owning their own care, so that when you go from place to place, you can bring on your phone, the link to your lab work, the link to your x-rays, the link to your last note. We do that with Jeff Chart, Epic has my chart. I can't tell you how many patients have come in to see me, and it's a number of strokes and a number of ways for me to get the information. I'll say, oh no, doctor, here I have my latest lab tests here. You can take a look. How wonderful is that? I mean, that is the application of technology to empowering the consumer, the patient. There has always been some bit of a knowledge asymmetry between the patient and the clinician. That helps to eliminate that, to to really enable the consumer to have that information at their fingertips about themselves. And that's incredibly valuable. That's incredibly powerful. I think we need to be able to make the patient, in a sense, if they're capable, be the link across these systems. I will tell you that it is, it's challenging to be an older patient to navigate systems. It's challenging to be a patient that doesn't have the same language capabilities to navigate a system. We have now capability in all of our practices to have an instant language translator through video connection. That makes it much easier to be able to communicate with folks in their native language. We cover about 240 different languages, so pretty much the care can be delivered much more efficiently. It previously was very difficult to do that when someone would come in from a different language background. We've also looked to bring care to the patient when they are with us as much as possible. What do I mean by that? So when we built the Honickman Center, which is our large medical office building, we put all the specialties in that center so that it would be a question of moving from one floor to another rather than one site to another in order to receive the care that was necessary. But we also did something else which is sort of interesting, and that is virtual checkout. So what we noticed was that we noticed this because of our folks that are on the spectrum that have challenges engaging with the front desk and other places. We said, how do we make it easier for them? They're in a room. How do we set up their appointments, get their pre-authorizations, get their studies and everything centered without them going to the front desk, waiting in line again, potentially unable to communicate with the front desk people as effectively as they possibly could? Well, let's just do it in the room. So now when you see folks at the Honickman Center and I'm finishing with a patient, I hit a button on the big video screen there, and the person from central scheduling comes on. Hello, I'm so-and-so, and I'm here to help schedule your appointments. I leave the room and they schedule the appointments for the patient. Some the same day if it's urgent, others when the patient's available. But the patient, if they're elderly, if they're having trouble with communications and others, they don't have to go to the front desk. They don't have to try to schedule things. They're not given a piece of paper to do it later. It's done right there. It's part of the access promise is virtual checkout. And that's been one of the best received things that we've done. It began because we were trying to help a certain patient population with challenges. And then when you do that, you actually help an entire other class that you weren't even considering. Folks that are having difficulty with hearing, elderly patients that can't get around as easily, folks where the language line is there already and doesn't have to be redone at the front. There's all kinds of benefits when we look at the most vulnerable among us and we say, let's take care of them. Oh, wow, now we've taken care of an entire different class of folks. And I like your phrasing, where you're asking about the folks that have challenges. I think when we commit to taking care of those that are most vulnerable, we help a lot more people than just those who are more vulnerable.
Yeah, I really like the fact that you've touched around some of the aspects, the solutions that technology advances are starting to give us. The idea of doing virtual visits, you can do virtual e-consults too as well.
Yeah.
The idea of a virtual checkout, we call these virtualization technologies. And we're seeing more and more advance around this. And one of the things you mentioned is how do we empower the patient and really engage them? Our CEO, Avinash Shashank, just wrote a book called Healthcare Autonomy. Patients want more autonomy, physicians want more autonomy, health systems want more autonomy, and maybe technology can help to drive some of that. And one of the barriers that I've seen a lot is the difficulty with engaging the patient between visits, whether they're in person or electronic. And then also, how do you measure true outcomes? Measure blood pressure changes, A1C changes, so that you can actually not look at proxy measures, but look at true clinical outcomes. CMS has been pushing the card with this new access model. Maybe you could share a little bit about where you see a vision for this idea of healthcare autonomy and practice virtualization leading us.
I really do think that continuous engagement is going to be the answer to a lot of the challenges that we face in terms of actually getting better healthcare outcomes. We're working with a company that actually can, by you holding the iPhone or other smartphone to your face, looking at the screen, they can actually know your pulse and your blood pressure. Now, measuring your blood pressure with a blood pressure cuff, even if it's digital, writing that down, getting that to the doctor, that is a big impediment to managing people's blood pressure. Or even worse, before, when you would just come to the doctor's office, you'd see the white coat and your heart would start beating quickly. So, the now at your leisure, you look at your phone. Oh, that's my blood pressure. I guess I better not have that double order of fries with salt today. We joke a little bit about it, but that is empowering. That is giving the patient autonomy, right?
Yeah.
The there are the smartwatches haven't quite gotten to the blood pressure. They do pulse. They do pulse ox. There are devices that, just like the insulin pumps have a monitor for blood glucose. There are devices that are now starting to do that, or potentially can do that. That's going to be the best bet in terms of managing
Mhm.
diabetes and things. I mean, if you see that your blood glucose is 300 after you've had a meal of Oreo cookies, well, you probably will tail back. We know what negative and positive feedback does. That's human behavior. If it's displayed and you know about it, then that's going to change the way that you react. I think the technologies are going to enable this. Part of the challenge is that the technologies aren't necessarily attached to a caregiver of some type. So, knowing your blood pressure, if you're able to control that through diet and other things, that's one thing. But another is to have an alert sent to a caregiver that, hey,
Mhm.
your blood pressure is 180 over 120. That caregiver then responding and saying, wow, your blood pressure is really high. What do we need to do to prevent you from having a stroke? You know, there are thresholds and alerts that we have to develop as a system, where we're going to intervene, and then we need to measure how that intervention actually results in an improved outcome. If you lower the number of strokes in a given community over a period of time, that's very powerful, but you have to measure it. You have to actually, to your point, do the outcome studies so you know that the intervention is actually beneficial. Um, I do think it's all coming, honestly, David. A lot of this can be processed through an AI measure that can detect signals and changes and then alert a caregiver or alert the consumer that they need to change behavior. I do think that that's coming. Whether it's an Oro ring, whether it's a smartphone, whether, there's a lot of different devices that are poised to 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 change the way that we deliver care. And to CMS's credit, part of what they would like to do is to do what we at Jefferson call lifestyle medicine. So, lifestyle modifications that result in improved health. Um, I also think that there's a bit of a overlooked aspect to this connectivity. When we do our social determinants of health, one of the things that was astounding to us is how many people list that they're lonely and they have no support system.
Mm.
This is an epidemic of modern times because people don't necessarily have groups, whether they're social groups, church groups, whatever, that they're engaged in. And especially happens as people age and their cohort dies away or becomes ill. There are a lot of very, very lonely people in
Mm.
this world. Having them connect to caregivers, to other communities, to other individuals that are in the same lifestyle challenges that they have, whether it's a hypertension group, whether it's a group for diabetics, whether it's a group that has a cancer diagnosis, whatever. If you can build that connectivity into your monitoring devices where a person has a friend as well as a caregiver,
Mm.
you're going to solve one of the really, what I think is a huge epidemic of our times, which is the lonely individual that doesn't really engage socially with others except for perhaps a limited computer type of engagement. That that is taking and empowering not just the individual to the point of your CEO, but empowering actually that individual by embedding them in a community that cares about them and whom they care about, and potentially solving a lot of other issues that arise that way because of the isolation people feel today.
Mm. That makes sense. And I really like this concept of better empowerment, better coordination. I would add not just professional caregivers, but the person who's actually connected to the person, their spouse, their neighbor, their friend, when they choose to engage them as well. All folks that can better collaborate and address many of these issues. One last topic I would like to get into that's top of mind, and then we can wrap this up. And I just lost my lighting again.
You get
Um,
your message.
yeah, that's. I guess we're not speaking loud enough for the lighting to trigger. Um, been a movement from fee-for-service medicine, paying for each service that's delivered, to a more value-based payment model, or what we often call population health. You know, at Jefferson, you've led much of the academic thinking about population health. Can you say a little bit about how these technologies and this issue about access to specialty care may play in with that movement, and where do you think we're heading?
I think that it's clear that we need to move to a value-based system, that it's not possible in the future for everything to be fee for service. The challenge is that nothing right now is built for value-based care in the sense that insurance companies aren't very comfortable with
Hmm.
value-based care. Hospitals are not very comfortable. Physicians are only now becoming comfortable with this concept. There's also the question of how do you take care of a large population, provide the care that's necessary when you don't have enough specialists, etc.
Hmm.
We're learning that AI is going to be able to provide some of that care. And I fully believe that in the future, clinicians will orchestrate systems of AI that will take care of much larger panels of patients and will do so even better than they do today because they're able to spread their expertise and spread their, you know, work across the entirety of a community because they're able to stretch themselves through AI. Um, if we can get that right, then I think we'll be able to solve that issue of how do we care for larger, broader swathes of the community moving forward. It you can't you cannot conceive of a fee-for-service world that will be able to deliver the care that's necessary, for example, for mental health. Estimates vary of how many individuals need behavioral or mental health care in the country.
Hmm.
There There are what, 50,000 psychiatrists in the country, most of them located in areas of population density. There are perhaps upward of 50 million individuals that require help. You know, you can't do that unless you use the technology that's available to help to deliver some of that care. And that's particularly what's so exciting about today, is because, all the things we've talked about are basically fundamentally caring, fundamentally empowering individuals. But before, we were never able to do that because we just didn't have the resources or the democratization of knowledge or access that we currently are able to pursue, given the changes that have occurred in artificial intelligence and in ways that we can access and help people. Um, that doesn't necessarily mean that you're eliminating clinicians as part of the equation. It just means that, that some parts of care can be delivered in ways that are more efficient and yet are going to be enabled in ways that weren't able to do, for as little as 3 or 5 years ago. So I'm very bullish on the future and bullish on the AI, and the really encouraged by a lot of the work that's been done to date, and the work that I think will continue to allow clinicians to care for a broader group of individuals, to return to the access consideration, but also to what you said earlier, we're also going to be empowering patients with that. That's wonderful. The If a person has the knowledge that is needed to be able to care properly for themselves, has a community wrapped around them that also cares for them, and has a clinician, a physician, or nurse practitioner that can help with the wisdom that's needed to apply that knowledge, then that's population-based care. That is
That's
what
great.
we've been talking about for decades, and what now finally technology has caught up to. That's value-based care. That's not paying for each bit of service that you get. And I'm very excited about that for the future, for all of us.
It's a very hopeful vision, and I love this idea of greater collaboration assisted by technology, giving great patients and physicians greater autonomy to do the things they need to do. For the health system listening today, and this has been a wonderful conversation, what is the one thing that you would give them a recommendation to focus on as a next step in closing a lot of these gaps around effective specialty care?
I would say trust the patient as your partner.
Hmm.
The patient wants to get better. The patient wants to be healthy. Once you realize that the goals are really the same for the patient and the community and the healthcare organization, then you start to say, okay, what is it that we can do to empower the patient, family, community? And if you trust the patient as your partner, if you look at it as a true partnership in health, I think that that's the way that health systems really answer the call. If we go from what we talked about at the beginning, there just isn't enough, to perhaps understanding that if we leverage all the resources we have, then we can look at it as an abundance rather than as a scarcity. Uh, it takes a lot of discipline, and it takes a lot of humbleness and listening to be able to accomplish that as a health system, to put people first. But for the first time, I think, in generations, there really is an opportunity to do that because of the new technologies that have been brought forward. It that is why I still have a very hopeful vision.
That's wonderful. Well, on that note, Thank you so much for joining us today, Edmund. This has been a wonderful conversation. It was a great joy speaking with you, and I'm sure our listeners have a lot of helpful things to think about as a result of this conversation.
It's absolutely my pleasure, David. Thank you for the work that you've done and the group has done in terms of helping to do exactly this.
Well, that's it for the Innovaccer Healthcare podcast for today. Dr. Pribitkin, and we'll end with this line. Innovaccer's podcasts are available on YouTube, Apple, Spotify, and most podcast platforms. So you'll find us on almost any platform, whether it's audio or video, and we'll see you soon. Thanks again, Edmund.
Care, everyone.